Hi everyone and welcome to Bloomberg UK, a special focus on the biggest challenges facing the British government, the economy, financial services and markets. I'm Francine Lacqua here in London. Now this week we're taking an in-depth look at Britain's struggling health service. The NHS has turned 75, but what will it take to survive to 100 and beyond? The UK government calls the health service Britain's most treasured national institution, but a recent report has found that it lags behind many other countries on spending, investment and health outcomes. At the end of April, almost 7.5 million patients were waiting to start treatment in England alone. That's a new record. Of those, 370,000 were waiting more than a year. The UK is well behind other major European economies on hospital beds, averaging just 2.5 per 1,000 people. Now, avoidable mortality rates in the UK are also higher than European peers. It all begs the question, can the NHS be saved? And what will it take to fix it? So let's bring in our panel of experts. Susie Ring, our healthcare reporter, and Olivia Konoti-Ahulu, our equality reporter. So congratulations, first of all, on this important piece of data. You have this amazing expose looking at what the NHS promised. You look at data, you crunch the data, and you basically put it together to say, how can you also fix it? Susie, whilst you were putting this together with the team, what was the most surprising? That out of the 8 metrics, the NHS is probably doing badly on all of them.
I think that's it. You know, the rhetoric that the NHS is doing badly is well known. There's been lots of problems for decades and a lot of underinvestment that's needed to be rectified. But with this analysis, you really got a sense of the extent to which things are going badly. So the fact that 1/5 of the constituencies are meeting none of the 8 indicators that we looked at. So these are the metrics that they should be meeting for things like wait times for A&E, ambulance handover delays. It was really the extent to which those targets aren't being met that was so surprising.
Yeah, and Olivia, I have to say that, one of the most shocking things is you realize that location really matters. So depending on your postcode, you either live or die if you have to use the NHS. Has it gone worse in years? What have you found out through your reporting?
Well, I think that was one of the other surprising things we found was the extent of the geographical changes. So as you were saying, in the southwest, for example, we were really finding that region, when you look at those specific indicators, was really struggling. And, there are some quite visceral feelings you find when you think that if I called an ambulance, would it get there in an amount of time for me to be okay if something really serious was wrong? And there is the sense that COVID, of course, created this backlog that is now very hard to come back from. And with staff pressures as well and the cost of living crisis, there is a sense that things have worsened to this kind of crisis point.
Yeah, if we take, some of the indicators, so ambulance waiting times, it's handover delays in ambulances, waiting times in A&E, hospital bed occupancy, same day or next day GP appointments, diagnostic tests, referred treatments, and then cancer treatment, waiting times. What's gotten worse out of those 8 categories?
I think the actual issue is that they're all really interconnected.
Yeah.
So one of the reasons we looked at these metrics is because they all had a kind of wait time element, so they were kind of comparable from that sense. And one of the paramedics I spoke to in Bristol made the really good point that, she's there outside waiting to transfer people into hospital, which is the handover delay point that you mentioned and that no constituency is meeting the target on. But the reason she's waiting outside is because there's no beds in A&E. Well, there's no beds in A&E because there's no beds anywhere else in the hospital, so those people have been taken to A&E, and there's no beds anywhere else in the hospital because there's not the social care to discharge people to. So it's this kind of interconnectedness that's really at the heart of the issue, and everything has a knock-on effect on everything else.
Yeah, and so if you look at the causes, it's very difficult to pinpoint. It's not only underfunding, it's the lack of staff, and Brexit probably exacerbated some of the concerns we have.
Yeah, exactly. It feels like there's this twofold issue. One is just the weight of demands. What everyone says is that people are getting older and people are getting sicker, very basically. So when people are turning up to hospital, they're coming with 2 or 3 very complex issues when in the past it might have been 1 because people are living longer, and that's only set to get worse. And then you have the NHS itself in terms of being what we all know, understaffed, underfunded, very low staff morale. So there's this sense of these 2 competing pressures, and it's not clear how that's going to resolve itself.
So there's not an easy fix, and as you say, it's all interconnected. So if you have a pressure point at one, there's a backlog on other parts. Is there anything that they can do more quickly to try and alleviate some of the pressure?
Well, we had the government publish its 15-year workforce plan last week, which is definitely welcomed, and everything in there, is very much what the NHS has been saying for a while in terms of we need more doctors, we need more nurses, we need more incentives for those people to train and stay in the UK. One of the issues we have is a lot of people train in the UK but don't stay in the UK because pay isn't as good, lifestyle isn't as good. So we had a lot of good narrative coming out from that in terms of more medical school places, making sure that those places are also particularly increased in those areas with shortages, because of course one of the dynamics is you will always have people in London, for example, who are top medical school students, people that want to come and live here because of the lifestyle, but you won't necessarily have that capacity in more rural areas. Yeah. So definitely workforce is a key part of this, and that has come out of the plan. But there are also other issues around technology reform, investment in old buildings and old hospitals. Again, this interconnectedness of you can't just fix one thing, you have to try and fix a number of things to make the whole system work.
How much can you actually fix with extra money and funding?
I think money is always going to help. If there's more funding, then you can pay people better, you can reform technology, you can invest in buildings. But money isn't the only thing. There is definitely just a sense that I think morale has ebbed so far over time that is going to have to take time to come back again. Also, it's not a quick fix. The government workforce plan is really talking about places coming in from September 2025. Well, we're in 2023 now, so we're not going to see the fruits of that for a good number of years yet. So it's sort of what's going to happen in that time, what are the sort of short-term interim measures that can be used to try and boost morale. I mean, obviously we're still having strikes over pay with junior doctors and ambulance workers and nurses. A lot of that really needs to get resolved for us to be able to step forwards.
And Olivia, the other trend is that, of course, a lot more people have been paying for private insurance, which just, increases the gap between the haves and have-nots.
Yeah, exactly. And I think one point that we found is that just because people are paying for private care, that potentially takes kind of staff out of the pool of the NHS. So it just kind of accentuates those pressures. And I was speaking to someone who didn't necessarily want to go private, but it was just kind of the small things where after she had a stroke, in order to really fully regain her mobility back and get back as well as possible, she just felt that those resources would not be available to her in the NHS. So she kind of said, if it wasn't for my savings, I just don't think I would be able to have the independence that I have now.
Yeah, when you look at some of the inequality to do with health services, do people, pay a lot of attention on the parties that offer what to decide who they vote, or is it almost a second thought?
Well, I guess Rishi Sunak has identified, the NHS is one of the key things he wants to focus on, and waiting times is one of his priorities to cut this year. So I think it's definitely on the minds of political parties, and the Labour Party have put forward their own agenda. So yeah, I think that the NHS is this, it's obviously a life and death issue, but it's also a very emotional one about how we identify to be British. So I would say it's high on the agenda.
All right, thank you both for joining us. Our equality reporter, Olivia Kunoti-Ahulu, joining us, of course, on this wonderful story. Susie Ring stays with us. Coming up, more on the pressures facing the NHS next with Ben Zaranko from the Institute for Fiscal Studies. This is Bloomberg. Economics, finance, politics. This is Bloomberg UK. I'm Francine Lacqua here in London. Now, as the NHS struggles with long waiting lists, budget constraints, staff shortages, and mass strikes, it's no surprise that more patients are turning to private healthcare. Research from the Private Healthcare Information Network shows that admissions to independent facilities hit a record high last year. There were 820,000 private inpatients admissions in 2022, with hip and knee replacements the fastest growing procedures to be done privately. Well, we're now joined by Ben Zaranko, senior research economist at the Institute for Fiscal Studies. Also joining us here in the studio with me, Adrian Woolridge from Bloomberg Opinion, and our healthcare reporter, Susie Ring, is still with us. Ben, thank you for joining us. Also, Adrian, thank you for joining us. Ben, when you look at the funding and actually what would make a meaningful difference to the NHS, how much pot can the government spend on the NHS, which is meant to be the pride of the UK?
Well, that's really a political judgment. And what we've seen in recent years, and since 2010, since the coalition government came to power, is the NHS be prioritised relative to other public services. Other public services were cut back really quite sharply during the 2010s, things like prisons, your local governments, the court system. Those services faced large cuts. The NHS saw its budget rise. Now, it rose more slowly than it had done historically, but it was still increasing. And that's been a decision that repeated governments have made. So you've seen the NHS take up a bigger and bigger share of the overall pot. But in terms of how far that can go, that's really a political judgment. I think the challenge facing whoever wins the next election is that some of these pressures from an aging population are really starting to bite. The number of people aged 85 and above is projected to increase by 40% over the next decade. Those people use a lot of healthcare. It's almost certain we're going to have to increase the health budget if we want to meet those pressures. And the question then becomes, where does that funding come from? So these pressures they've been known about for a long time, these pressures from an aging population, but they're really starting to bite, and it's going to force some very difficult decisions.
But Ben, and this is crucial, right? Without, I mean, I guess hindsight is a wonderful thing, but if you look at the underspending that successive governments have done in the UK, is it because they didn't model an aging population that needs more care, or did the pandemic really put them off track?
Well, I guess underspending is in the eye of the beholder. We're spending more in the UK than we ever have done in the past. It's true that we spend less than some of the Western and Northern European countries to which the UK is fond of comparing itself. But it's also true that the UK spends more than lots of countries in Southern Europe, for example. So the UK is sort of in the middle of the pack amongst the EU. Given the UK is sort of in the middle of the pack in terms of its GDP per capita, that's perhaps not to be, not too shocking. And I think that really, since 2010, the decision has been to protect the NHS while cutting everything else, and the bigger increases for the NHS budget have been precluded by concerns about the public finances and perhaps a reluctance to raise taxes towards those Western and Northern European levels that other countries have in order to fund their health systems. So there's choices along the way that have led us to where we are.
Okay, so let's not call it underspending, Adrian. Let's call it broken NHS. Is there anything that works, from the NHS right now?
Well, I think the problem with the NHS is that we have this rigid distinction in our minds between public and private. That private has to go in this completely separate sector. And I think one of the ways forward would be to introduce insurance to top up public spending, so people could actually go into NHS hospitals but use health insurance to top up, either to get faster service or to get better food or to get separate, better rooms or something like that. So keeping these things completely separately, religiously separately, I think is a very questionable thing. And the other question, of course, is whether you could have top-up fees to go into. But as long as we have this rigid notion that you can't pay any extra within the context of the NHS, people are forced to go private.
Yeah, which 10 years ago, certainly if you're a foreigner in this country, you think it's amazing because you have everything for free. And if you look at the other European models, it's just not the case. Usually you pay something and you get it reimbursed. Susie, does the NHS survive in its current form?
I think we have this tension where this idea of having healthcare free at the point of need is incredible. That is such a privilege in a country to not have to worry about financial burden, not have to rack up debt like we see in the US. People have kind of medical bills that, bankrupt them. And that is that's a real privilege. However, when it gets to the point where actually, yes, finance isn't prohibiting you from going to A&E or the doctor, but the fact that you'll be there for 12 hours is prohibiting you from going, or you can't get a GP appointment for a week or two, even though you really need to see someone. That's a different kind of prohibition. So I think something's got to give is the answer. And one of the things I thought was quite interesting that came out of the King's Fund report they did a few weeks ago was that it's actually quite hard to totally change your healthcare system. So countries' healthcare systems are quite tied culturally to who they are as a nation and have been born out of, ours has been born out of the Second World War, and there've been sort of foundations that underpin them that you can't really just transfer and think, oh, Germany's got a better model, let's take that. But there are tweaks and things we can definitely learn from other models that would help reform it for the next generation.
So, Ben, how do you look at staffing? If you increased staffing, so either because people thought it was a great job or you paid more, so some of the nurses and great doctors that we have at the NHS, would it make a meaningful difference?
I think one of the puzzles at the moment is that the NHS has quite a lot more frontline clinical staff now than it did just before the pandemic. And yet the NHS is managing to treat fewer people every month than it was prior to COVID, which suggests that staffing isn't the only thing that matters. It seems clear and obvious that with a growing population, an aging population, we're going to need more healthcare staff at some point. And that was a very clear lesson coming from the government's workforce plan. But I think it also seems clear that if you just keep chucking more and more staff, frontline staff, into a system that isn't working very well, then it's not obvious that you'll get better outcomes. And so I think the focus on staffing, where there are undoubtedly legitimate concerns about morale and retention and so on, has to be coupled with a focus on the other things that might determine productivity, whether that's the management system or the role of data analysts or the capital equipment available to staff or the number of beds available or the IT systems, and all these things that clearly are going to matter as well, and thinking about how we can use the resources we've got more efficiently, more productively, rather than just the answer immediately always being, oh, we need more staff, we need more staff. So I think there has to be a broader conversation going on.
But Ben, as the Bloomberg article writes beautifully, right, the emergency care is the most visible, but a harder problem is all of the backlog of these non-urgent procedures. So is there a backlog that requires a different system? Or is it fixing it through just having more nurses? I mean, I don't know the last time you tried to get an appointment for, through a GP, NHS, but Central London, it's almost impossible for at least a couple of weeks.
Absolutely. There's very clearly pressures on getting access to a GP in the first place. It's right, preventing some people from joining the waiting list. The irony is that the backlog might be even greater if people were able to actually join it. I think that the NHS is clearly trying out new models of care. So to give one concrete example, they've been doing more what they call hot and cold sites. So having hot sites where there's an A&E department, for example, and things can get disrupted if there's a big influx of patients, but having cold sites where they don't have to worry so much, the patient flow is much more predictable, and so you can just churn through more of your routine operations and avoid them getting disrupted by COVID or other things. So I think there's new models of care there, which I think are working quite well. But there's clearly, if you look nationally, a big issue here about a struggle to treat enough people to get the waiting list falling. Now, I don't think we have a solid evidence base on this yet, but there might be reasons to think that longer waiting lists are perhaps partly responsible for some of the worsening in population health we're seeing, more people inactive due to poor health, more people claiming disability benefits. It's at least plausible that the NHS is playing a role in that. So there could be economic benefits from sorting this out as well.
All right, and Adrian, quickly, when you look at private healthcare, is that a good or bad? It takes pressure off, but I wonder whether it also takes doctors with it.
To some extent, but what I would argue for is private healthcare as a supplement to the NHS. So you actually had private wards in NHS hospitals until the late 1970s, when the Labour government got rid of it. It's this notion that you can't mix the two systems that is so derogatory in Britain. If you look at other countries, if you look at France, Germany, Switzerland, there are all ways in which you can use a tax system to support, or a compulsory insurance system to make sure that everybody gets access to free healthcare, but then you can top it up with different levels of personal payment. The problem with Britain is we're obsessed with the American example. We think we either have this wonderful quasi-religious thing called the NHS, or we have America, and you have people dying in the streets. There are many, many alternatives, and all of those alternatives, I think, make some use of a mixture of public provision or compulsory public subsidised insurance with an ability to top up the system, because you can get more money in that way.
Okay, and we'll talk a little bit more about that. Thank you all for joining us. Ben Zaranko, Senior Research Economist at the Institute for Fiscal Studies, Susie Ring and Adrian Woolridge. Stay with us for more on this important topic. This is Bloomberg. Economics, finance, politics. This is Bloomberg UK. I'm Francine Lacqua here in London. Back to our deep dive into Britain's struggling National Health Service. With me, Susie Ring, our healthcare reporter, and Adrian Woolridge, our global business columnist for Bloomberg Opinion. Now, Adrian, you said something that really struck with me is, the problem with actually reforming the NHS is that a lot of politicians say, well, we don't want to be America because there's no free system.
Yeah.
But is there, if not an easy fix, something that we need to strive to get to, because it can't survive in this current state?
Well, the most important thing is that we have to stop treating it as a religion. I think the extraordinary thing that happened yesterday was having this church service in Westminster Abbey, celebrating the NHS. We should be thinking about different examples from around the world, and those different examples have certain things in common, that they have a basic system which provides basic care for everybody, but they allow other sorts of money or other sorts of top-ups to come into the system. And in Britain, that's verboten. The idea that everybody gets exactly the same service, that they can't top things up is essential to our sense of national identity. But it's a sense of our national identity which is in danger of destroying the very thing that it celebrates.
You also have a new opinion piece out today, which is, a really great read, talking about conservatism and the difference between the US and, of course, here in the UK. I mean, are the NHS fault lines, to blame because of the Conservatives and also the austerity years?
Well, one of the many problems with the NHS at the moment is that we had a long period of austerity introduced from 2010 onwards by David Cameron and George Osborne. And we're feeling the effects of that now. They did two things that were bad, I think. One was that they cut back very, very significantly on long-term investment in the NHS. And the second is that they didn't tackle the community care problem. In fact, they were cutting back on local government expenditure all the time. So we did have a golden opportunity then, because borrowing was virtually free, to do something about these long-term problems. We can't now because it's expensive to borrow, and we are suffering from the consequences of that. No proper community care system and an NHS that has been squeezed for a long time.
All right, thank you both for joining us. And again, congratulations on this important, if sad reading, looking at the data and seeing what the NHS will do in the next 5 to 10 years and beyond. Susie Ring, our healthcare reporter, Adrian Woolridge, Bloomberg opinion columnist. Now, Bloomberg Surveillance Early Edition continues in the next hour. Kriti Gupta in New York, our Guy Johnson here in London, and this is Bloomberg.